Is that up? Can you see that?
Yeah.
You see the slides?
Yes.
We're all good, Jay.
Perfect. Okay, so what we're going to do today, and again, thanks everybody for joining.
Yes.
This is a lot of work to kind of get ready to go through this. What I want to show is and again, just so that everybody knows, I don't know, this is really rolling forward. Sorry, you guys. Let me get back. I don't want to, I'm just the president of the Rhinoplasty Society, and I've been in practice for a long time. And I just note that I went to medical school in Manhattan from 1990 to 1994. And I remember when HIV and AIDS, basically 50% of the population of New York Hospital had AIDS or HIV when I was in medical school. So I have experience in terms of understanding that things have to be very different. And that's sort of the main theme, I think, today is how are they going to be different? I'm not an infectious disease expert, and I'm not a politician, and I'm not a policymaker. And our goal today is not to make policy. Our goal is to discuss options, thoughts, and concepts so that people can have a good idea about how to return safely to practice in their area. A lot of this is locally dependent. Los Angeles is different from Bull, is different from Cleveland, is different from South America. So again, this Rhinoplasty Society is a small group, and I do appreciate everybody jumping on. We had over 1,000 registrants. And I do think that we have some experience with rhinoplasty in our society. So hopefully we can really come to some ideas about how to go forward safely. The world is definitely different. There's no way to eradicate this virus. It's here to stay, and patients want to have surgery. So with that, we must change. Everything has to change, the way that we think and do things in rhinoplasty. And Dr. Sajadian will go through why that is, and same with Dr. Davis. Got to be smart and be informed and know what's happening. I'm going to say it again, it's locally, and understand your patient and your operation. Test your patients, test yourself, and test your staff. These are sort of my general concepts when I'm going into a rhinoplasty operation now. And this is a very key point. I've said it before, I'm going to say it one more time, that your patient has to be an active participant in keeping themselves and your staff safe. They can't just go along for the ride. They have to understand that the world is different too, and that they are part of the solution to making it safer for everyone to have rhinoplasty. There's no right way, and every part of the world is going to be unique, and customization is how we're going to have to see this. And what happens before surgery, the day of surgery, in the theater, and after surgery, all have to be considered long before the patient shows up. And so as people are returning to their practices, what you're going to do to your staff to do in all of these situations are crucial to the safety of the patient and yourself. I think that our PCR is most specific, but we'll talk about the antibody test today. And again, we want to reduce the risk by knowing what's going on with everybody who's in surgery. It doesn't mean somebody's not going to get into the operating room who has COVID-19. It's going to happen. These are the things that I'm doing. We'll go through them very, very much in detail, but I think, again, it's all about testing. I'm going to blow through the rest of these very quickly because we're going to talk a lot about them. And again, I did a podcast with my associate, Millicent Ravello. It's worth listening to because we've this is really good. I guess if you're in Beverly Hills, it's probably very different if you're in Tallahassee, Florida, or Miami for that matter. And we'll hear from Rick Davis about that. But it is useful to listen, and I want everybody to be safe. So with that, those are my opening comments. And I want to unshare my screen here and let's get Dr. Sajadian on.
Thank you, Jay.
So you should be able to go ahead, Ali.
Okay, Jay, let me go in here. Okay, thank you, everyone, friends and colleagues. I'd like to quickly share a few ideas about how we can do rhinoplasty safely in the COVID era and some clinical consideration. Let me just time myself so I can stay on time. Are you seeing me? You okay, Jay?
Yeah.
Okay. So this overview of my talk, just few words about the virus and why as rhinoplasty surgeons we are at higher risk, and some clinical consideration and the strategies for increasing the safety and decreasing risks. As we know, the severe acute respiratory syndrome, COVID-2, is highly contagious and has high morbidity and mortality compared to other coronaviruses. And as of last night, there was 4.4 million confirmed cases and over 300,000 deaths worldwide. And according to CDC, 28 states have reported more than 10,000 cases. And in America, we have 1.9, and in Europe, we have 1.8 million cases according to WHO. So why, as rhinoplasty surgeons, we are at higher risk? There are 4 reasons for that. The sinonasal cavity is a major site of infection by SARS. And to understand why, we look at the structure of the CoV-2, you can see a number of spike protein. And these spike proteins are where the virus uses to attach itself to the host cells. And these receptors on the host cells are called ACE2 receptors. And the virus attaches itself to the respiratory cells in the, and specifically goblet secretory cells that produce mucosa, is shown to have 2 proteins that the virus can attach itself to. Jay wanted me to specifically talk about that. So here it is. You can see the respiratory mucosa inside the nose and nasopharynx, which has a high level of spike protein. That's why the virus can propagate there very easily. Second reason is that there is a high level of viral shedding, which appears to be highest at the nose, and therefore it reflects a major source of transmission. In a recent study just published a month ago, it showed that as a clinician, surgeons, healthcare-associated infection has happened and does happen with otolaryngology, oral surgeons, and rhinologic surgeons. And now it's considered to be, we are considered to be high risk for transmission. And so that brings up to what Jay was talking about, which is the importance of screening and testing of COVID-19 patients. Additionally, rhinoplasty poses a unique challenge due to the potential for aerosolizing the virus. This is important. So as we know, the virus can survive up to 3 hours and has an estimated half-life of 1 hour in the aerosol. However, on other surfaces can still survive for a longer period of time, which brings us to the point of cleaning and disinfection of the environment. And yesterday, WHO put out these guidelines for outpatient and ambulatory care setting. So the question is, for our practical purposes, can we potentially learn from previous studies of the irrigation suction aerosol data, laser data, or dermabrasion data to know what we should do? To look at this nice study was done by other colleagues in orthopedics, which showed that the irrigation suction procedure during operations was one of major sources of aerosol. Other colleagues from UPenn rhinology division with the virus surviving. So my own thoughts based on talking to a lot of colleagues is that this is just my own thoughts, not the guideline. To minimize the particulate formation, you should consider looking to see if you should decrease the use of these instruments, such as microsaw, drills, birds, electric grass, shavers, piezoelectric devices, and micro debriders. I also think that I used to use a dual splint in the nose. We should consider not putting intranasal splint to minimize the intranasal debridement in the office after surgery in the post-op period. And instead you use quilting sutures. Everything is done to minimize the risk. I know my other colleagues will be talking about strategies to minimize the risk. But as we know, virus is here to stay, and the troubling potential for additional waves of pandemic exists. So I joined these around the world should get together with some information on safety, potentially by utilizing cone beam CT, which has low radiation until we have better treatment and vaccine available, and also figure out what the role of telemedicine is. Our colleagues in American Academy of Otolaryngology have also come up with some priority lists, and they put in septoplasty, septorhinoplasty in a routine priority. Our colleagues in European Academy of Facial Plastic Surgery, Dr. Saleh et al. Had also come up with some guidelines for healthcare workers that come into contact with patients with COVID-19. You can read this, but this is just if you have come into contact. But as a patient in the operating room, for example, we can use pledgets in the oropharynx and nasopharynx. You have the patient preoperatively mouthwash with providine, iodine solution agents. In conclusion, it's important to know the nasal pathophysiology and know that it's important site of infection and viral shedding is very high at that level, at that area. And repeated testing and screening are key to prevention, and should come up with solutions with surgical strategies to minimize aerosol formation in OR and in clinics. And we can learn every day about this virus, and should come up with some local and regional epidemiology as a guide to have a focused action on this. I hope this was helpful to you all. Thank you.
Thank you, Ali. I want to get a specific comment from Dr. Gairon and from Dr. Jeffrey Marcus. So Dr. Gairon, from your standpoint, what are the key safety issues knowing that this virus is living in the nose and the pharynx, and with the way that we do rhinoplasty with lots of suction, some use more Bovie than others, some even do laser turbinectomies. How are we going to be thinking about this going forward from your standpoint?
Jay, thank you for inviting me. Good afternoon, everybody. Good evening. For those of you who are from Europe, I think this is a very different era. And Jay, you summarize a lot of things very nicely. And we need to think about the stages. First, we need, and the most important thing is not operating on somebody who has virus and doing a lot of, taking a lot of steps to minimize a patient who potentially has the virus to get on our operating room table. From there on, if we take enough precautions, the other changes are not going to be, in my view, as relevant, because we're going to augment the safety of the operation by preventing a patient who has the virus getting on the table. What we do is, first, before the patient goes to the operating room, before the patient comes to the facility, we take a history. We actually have a page questionnaire. Where they have been ever in contact with somebody who potentially had the virus? Have they been tested? And those are the factors that are going to actually isolate the patients. The surgeons and the patients all are monitored for temperature before, again, they enter the facility. And after they enter the facility, we all use masks. The patients use masks until they get to the operating room. And when you think about it, when the mask is on, I think the effect of the mask is grossly underestimated. In fact, had we taken the temperature of the patients, individuals who enter the country, had we advocated use of the mask, we would not probably have been where we are. When somebody has a mask on, is not going to touch the face, is not going to contaminate himself or herself or somebody else so easily. So after the surgery, again, patients get the mask on. The surgeons and the staff all the time are going to have the mask on. So when we adhere to these principles, we're going to greatly reduce the potential for any patient, again, being operated on who was potentially contaminated. And intraoperatively, yes, irrigation is going to help. Again, we need to reduce the droplets as much as we can. But I'm not going to change my surgical technique and principles to that, in my view, make a difference in terms of the outcome of the surgery to minimize the infection. Because by then, if the patient is in the operating room with the virus, I'm not sure that actually having the doses that would make or may not make a difference. So those are the things that we need to, all of the efforts should be on prevention.
Thank you, Bauman. Dr. Marcus, can I get your perspective as well?
Yeah, thanks, Jay. Can you hear me okay? Can you hear me, Jay? Okay. Okay, good, thanks.
Yeah, I can hear you, sorry.
So yeah, first I do want to say thank you to Jay for setting this up, and for those of you who participated in the organization, thank you for doing that, and to the Rhinoplasty Society for acting as host. It's a critical time. There have been a number of these webinars that we've seen from various places. RSC has had one recently on the South African Society. Rick was there and had some really valuable comments there as well. So there's a lot of information out there, and I don't necessarily think that we're going to know, with finality what the long-term protocols are going to end up being. I don't know where we'll be specifically a year from now. So we're trying to work this out as we go, and we're doing the best we can. Your comment about knowing the local situation is very, very important, because everybody has access to different resources depending on where they are, and they have different problems also where they are too. Among those things, access to testing. So to Bauman's point, the best way to prevent having a problem with a patient in the operating room is to prevent a patient with the virus from getting into the operating room. So I completely agree with all of those things. And I know we're going to get on to the issue about antibody testing and PCR. I'll tell you one thing, just from an institutional point of view, what we're here at Duke doing, it's universal across our health system. And you all have seen this, you probably have similar things in your own practices, but testing prior to surgery, in our case, it's a 48-hour window that's mandated, but it's not just that the test be done, and it's not just that it be PCR, which is what Duke is requiring. It's also where the PCR testing is being done, because the quality of the testing is very much center specific to the location and the facility that's performing the test. So why we're going to hear that there's variations in the sensitivity and specificity even with the RT-PCR technique. Why is that? Is it because they're doing the technique different? Well, some of it has to do actually just with the facility itself and the quality of and cleanliness and processing within that facility. So one contaminant from one sample could potentially lead to contamination within the facility. So for that reason, I can say, my institution at Duke, they're requiring that the testing be done, and we have a short list of places where it can be done. It can be done at Duke. It could be done down the road at a facility run by the University of North Carolina. And also one that many of you may have access to is LabCorp. These are facilities that Duke has determined are practicing within the highest level. And to that level, they're demonstrating a 99%, well, actually a 1% false negative. So basically, somebody comes in, they get a negative test, they're negative. And they believe, at least my institution believes, that if it's done in these facilities where at least they're familiar with the testing, that they're willing to accept that. So within a private practice environment or wherever anyone is, it'll be incumbent to find out where the highest quality testing is being done in the area, and then come up with a protocol to use that. So that's one thing I just wanted to lean in on. And then, Rick had said the other day, management of the turbinates is going to be one thing that will be challenging, because the modalities that we use, I would normally favor the microdebrider technique, and I would use Doyle splints to hold them out of the way and prevent Synechia and so forth. But that's probably not something I'm not going to do. I don't know about others, but I'm probably not going to do that. Doing turbinate reduction, partial turbinate reduction using the shears, like was taught when I was a resident. I'm probably not going to do that because the post-op care, it's not the intra-op care on that, it's the post-op care that's a problem. Irrigations, crusting, and so forth. So I think that probably I'm going to be led to do, if looking at the efficacy and the long-term efficacy versus risk profile. If you look at that curve, we always talked about turbinectomy and microdebrider having the greatest efficacy and also being a long-term success. The one that has the lowest long-term success seems to carry the least risk, which is turbinate out fracture. So there's very good likelihood that I'm going to be doing a fair bit of turbinate out fracture until I can figure out, what is going to be the next, the standard. So I started by saying a year from now, things may be different. But now that, I'm operating now, you guys are all operating, I'm going to operate tomorrow. Until I can figure out otherwise, I'll be, lateralizing some turbinates.
Let's, on that topic, let's get to Rick Davis, because he has a lot to say about safety and how he's looking at it too. And let's continue those thoughts. Thank you both, Dr. Guyron and Dr. Marcus. Rick, you want to go ahead and share your screen? Got to unmute, Rick. We can't hear you. Rick, I think you're muted.
How about now?
That's better.
So I thank you all for including me. I have nothing to declare, and for once, I don't give a flip if somebody wants to take pictures of this. That's fine with me. I'm going to go quickly because I have a lot of data here, some of it a little bit redundant. So we know that this disease is hallmarked by fever and cough. Those are the two most prevalent symptoms. And as Bauman wisely pointed out, you should screen them before they ever get to your office to make sure they don't walk in with active symptomatic disease. A large percentage of people who are infected will never get symptoms or experience such vague symptoms that they won't realize they're sick. So you should treat all patients as though they are infected. Those who are at increased risk for severe illness include people with chronic lung disease. That's because the first organ system to take a hit from this is the lungs, and that's because the ACE2 receptors are very high in the lung, the kidneys, the liver, and in the heart. For rhinoplasty patients, lung disease might be asthmatics and younger people or people who smoke or vape. Cancer patients, whether they have active cancer or were treated in the past, are at a significant high risk, about a five-fold increase over non-cancer patients for severe disease. Any immunocompromised patient, this is another major risk. That could be somebody just with HIV, even though it's compensated by medications or prior malignancy or various other reasons like chemotherapy or some underlying disease process. Hypertensive patients also are occasionally seen in our patient population. This is the most common comorbidity, is hypertension. So if you take all people who get symptomatic and get ill, a great many have hypertension, diabetes, and cardiovascular disease. That's number one, number two, and number three most common comorbidities. Cerebrovascular disease, chronic liver disease, rheumatic disease, and don't forget obesity. A body mass index above 40 puts you at much higher risk. Transmission, we all know that it's either through touching an infected surface and transferring it to your mucosa or through inhalation. And inhalation is believed to be responsible for most patients, their mode of transmission. Live virions were detected on surfaces as much as 9 days after contamination, but most of them, it's about 3 days or less, depending on the type of surface. Incubation is the time from exposure to the time someone develops symptoms, and this can range from as little as 48 hours to as long as 25 days, but the median incubation time is 5 days. There are roughly close to 98% of people, if they're going to develop symptoms, will develop it within about 12 days. It's believed that 86% of infected people go undocumented, mainly because they don't know they're sick. But 18% of these people can still infect others, and that's why we've seen community spread so rampant. So again, treat everybody as though infected. Viral shedding begins about 2.5 days before the development of symptoms. This is important because your testing window needs to be less than that to have any kind of security that you're taking your patient to the OR without disease. The shedding during the incubation accounts for almost half of disease transmission. Viral loads get worse after symptoms develop, and they're most prevalent in the nose and nasopharynx for most of the course of the disease, at least in terms of what's going to generate aerosols. You're not going to get aerosols from the kidney or the liver or the brain or the heart or to a lesser degree, the lungs, as much as you will from the nose or the pharynx. Symptoms generally resolve after 10 days, but shedding continues for up to 2 weeks later. And in the severely affected individual, there are 60 times greater viral loads. So shedding is much more problematic in these individuals. Once you become symptomatic, you have about an 81% chance of having a mild illness that resolves spontaneously and you don't need hospitalization. About a 14% chance that you'll end up in a hospital, and about a 5% chance that you'll be fighting for your life. There was a study out of Wuhan that I think most of us are familiar with, where they looked retrospectively at 34 patients that went to the OR with disease for urgent surgery. I'm actually quoting the wrong paper here. This is in regard to testing. Nasal testing is very low sensitivity, between 63 and 64%, but chest CT is up to 98%. So as an adjunct to a negative PCR, you could also consider a CT of the chest, because even asymptomatic changes or patients can have radiographic changes visible on chest CT. You know, is it worth the money and is it available? That's another issue. Nasal examination, instrumentation, even endoscopy, and certainly surgery all stir the pot. They release particles into the nasal cavum, and then through the process of ventilation, inhalation, and then exhalation, these viral contaminated particles are released into the ambient environment, much more so if a cough or sneeze develops. So as clinicians in the operating room during intubation, extubation, and all points in between, we need to do our best to avoid triggering coughs and sneezes in our patients. Because the nasopharynx and nose are high reservoirs, there will be aerosolization to some degree, and it can last for 3 hours if the air is static. But if you can keep the air moving, that's a different animal. General anesthesia is thought by many to actually increase the intensity or severity of a COVID-19 infection. Mask ventilation during intubation, positive pressure mechanical ventilation are thought to aerosolize the lower airways, driving the virus down into the alveoli, which are rich in these ACE2 receptors. And general anesthesia also is responsible for causing some measure of immune suppression. I haven't read the literature on that, so I can't comment, but apparently it's fairly settled that some measure of immune suppression can occur in some surgical patients. After surgery, you know, removing packing or manipulating the nose is just as high risk a procedure. And that has prompted this kind of ad hoc group of head and neck surgeons to say that all elective procedures on the nose should be postponed. I don't necessarily agree with this, and this was not a group sponsored by any organization. This, I think, was just a group of surgeons that came together and published what they thought should be the restrictions. Here's that Wuhan study, 34 asymptomatic COVID-infected patients undergoing surgery. They revealed a 20% mortality rate. However, the 7 patients who who succumbed underwent major surgical procedures and had at least one pre-existing comorbidity with a relatively high median age of those patients. I think this group has the potential to shed a lot of light on what's happening. The International COVID-19 Surge Collaborative is a database which now holds almost 10,000 cases. They admit the data of any surgical patient who developed COVID-19 perioperatively with symptomatic disease, whether they got infected before or after. The initial data on this came from 235 hospitals out of 24 countries, so it's a very large number of facilities participating. They found that 26% of patients were infected before surgery, 74% developed symptoms after surgery, most of whom had surgery for benign disease like an appendectomy, but a quarter of those were cancer patients and 20 of them were acute trauma patients. The overall mortality in this group was 280 patients. For elective procedures, it was slightly less, and for emergency procedures, it was slightly more. But in this particular cohort, 1 in 5 people succumbed to disease. Half the patients developed pulmonary complications, and that put them in a higher mortality group of 38%, whereas the other half that got no pulmonary complications and tended to fare much better. This 38% is compared to an expected mortality rate of 8% from the pre-COVID era. The risk factors that they identified are age being a big one, as is an ASA, American Society of Anesthesiology, categorization greater than 2. Male patients, for some reason, there was a predilection for males. Cancer patients, clearly. Emergency and major procedures also. But whether you got the disease before or after the procedure did not have a bearing on your severity of illness. So some food for thought. Consider postponing elective rhinoplasty in patients who have a high risk of exposure. You know, they haven't been able to social distance, or they've been traveling to places that are hotspots, or et cetera. Patients with comorbidities, particularly elderly patients, that should be a consideration, especially if you're in a hotspot yourself. The testing should occur as close to when scalpel meets skin as possible. You want your test to be valid, and you don't want there to be a long interval between the test and when you operate, if for no other reason that the patient, A, could become symptomatic, and B, might get infected elsewhere. Avoiding power tools. You don't want to use IV sedation because there's a chance that the patient might aerosolize more or cough or flail about. Awake intubation is discouraged for the same reason. It's hard to get them numb and not coughing and moving. Laryngeal mask anesthesia is felt to have an imperfect seal. So a cuffed endotracheal tube with a rapid sequence induction and probably spontaneous ventilation, so you don't have to use positive pressure ventilation, is probably your best option. If you put lidocaine in the cuff, it'll help with extubation and minimizing cough. Using sequential compression devices to prevent DVT, because the cytokine storm that develops as this disease progresses tends to cause multi-organ thrombosis. And this is why shunting occurs in the lung, and one reason hypoxemia is so profound. It's not just ARDS, it's ARDS with thrombi, and thrombi develop in the kidneys, in the liver, sometimes in the brain. And then there's myocarditis in the heart, and sometimes significant elevation of isozymes and cardiac dysfunction leading to shock and death. If you have smoke evacuators, the kind that you would use on a laser procedure or a CO2 procedure for laryngeal HPV, then employ those. You know, you could tape the thing under their jaw and have it scavenge the aerosols that are coming out of their surgical field. Betadine, I think Rod's going to talk about this, so I won't go any further. I agree with Jeff. I think, you know, just bluntly outfracture the turbinate and don't stir the pot there. You're more likely to get epistaxis, and you do have wound care issues with that after the fact. Nasal packing and splints should be avoided if possible. And then, you know, give some consideration if you're in the middle of a surge to waiting a bit for things to settle down. A cure, vaccine may be around the corner, it may not, but it is, you know, it is likely that at some point those things will be available. So these are my references. If anybody wants to do a screenshot, this last one down here is a YouTube link for this collaborative. They're going to have their first paper out in the Lancet. It's been accepted, but it's in press. And I spoke to the head of this collaborative by email yesterday and stressed the fact that the other end of the spectrum, the low risk patients, need risk quantification, and they're working on that as we speak. So with all that, I thank you and turn it over.
Great, thanks, Rick. That was excellent. You really hit the highlights from the data standpoint, and that's perfect because.
Well, and all of it's reference from research, although admittedly, you know, it's kind of crappy science, not by design but by necessity. There are small patient cohorts. Most of those were retrospective studies, and it's not exactly the best data, but it's the only data. So it is what it is, and take it with a grain of salt.
Well, we will discuss that in a second, because what I wanted was for Dr. Most to go through what they're doing at Stanford, since they've been really hot on this, and he's literally at the epicenter of what's going on in Stanford. So want him to take us through what's going on there, and then we're going to talk about this in a panel discussion right after Dr. Most. So go ahead, Sam.
Sure thing. Thank you so much for having me. Thanks for organizing this, Jay. I'm going to share screen now and make sure this works. You guys see that okay?
Good, yeah.
Okay, all right. So hopefully this advances here. So I'm going to talk a little bit about what we're doing here in Stanford in the Bay Area. Did that slide just advance for you?
It did, yeah.
Okay, good. All right, so I want to make sure. So my only disclosures are I have, since my illness, invested in a couple of companies that have therapeutics. I'm not going to talk about them in this talk. But the main things that I want to say, the take-home messages, are things you may have heard already. You know, this is a brand new pathogen, a brand new disease process, and Jay's relating what happened with HIV in the 90s or 80s and 90s is very interesting to me. The evidence base is very thin at best. It's developing on a day-to-day basis. You know, there were headlines a few weeks ago that said smoking actually protects you. There were headlines that said that if you take ibuprofen, it's actually worse for you. So, I mean, these things, there's so much evidence flying around without much to stand behind. So I just think you have to really be careful what you say, because what we think is true today might not be true tomorrow. We cannot create absolute recommendations for best practices until we know the truth. But if we keep the best interests of our patients, staff, and community in mind, we will do the best by our patients and our community. You have to look to your local governments and hospitals for recommendations for your community. What I talk about, what's happening here at Stanford, isn't necessarily true for what's happening across the Bay or up in San Francisco. So, you know, it's really, really very localized. Okay. So what to avoid, you know, I'm just going to say this: don't make assumptions based on thin or no evidence. Don't make countrywide or worldwide recommendations, and do not make all-encompassing statements or guidelines. Unfortunately, this was just published. I'm just going to say it because I know it's on everyone's mind, and it's been controversial. And I think that these authors may have had their heart in the right place, but what they've written does look like it's some sort of all-encompassing guideline. And I know some of these folks are very nice folks and very wise, but I think this may lead to some problems. You know, the countrywide goal and the worldwide goal is to flatten the curve so that the healthcare system capacity is not overwhelmed. You've seen that get overwhelmed in places like Northern Italy and in New York. And fortunately, we were able to avoid that here in California. I'm going to talk a little bit about this. this is the status. We had 52,000 cases when I gave the talk for the Rhinoplasty Society of Europe a couple of weeks ago, and now we're at 76, almost 77,000 cases. And what's happening up here in Northern California isn't necessarily the same as what's happening in Southern California, and that's going to dictate what happens. Here shows the hot zones by actual cases per 100,000 people. You can see in that regard, the Southern California area is a lot hotter right now. And if you look at statewide case statistics by county, and this is shown here on the left side, you can see Los Angeles County has almost half of the entire cases of the state of California. And my county is Santa Clara, which is 2395. It's about 5th or 6th on the list. And so we have far fewer cases, although we were one of the first places to have the outbreak occur that was documented. And if you look at by hospital, number of positive cases by hospital, again, LA has got almost 1,700 cases, and down here at Santa Clara is only 48 cases total of people that are hospitalized that are known COVID positive. So definitely different areas are going to have different statistics, and based on that, you're going to have different recommendations. These are, as of yesterday's numbers, what the number of cases and deaths looks like in California. And I think this is of interest because if you look at the shelter-in-place date, which was about March 19th, you can see there's a 2-week lag before the number of cases shown in this left graph began to level off. And the deaths, of course, occur a little bit later, so it takes a little longer for that curve to start to flatten. And what's more relevant to us here at Stanford is what's happening in the Bay Area. And in the Bay Area, shelter-in-place was instituted on the 16th of March. And again, about 2 weeks later, the curve started to flatten. And for us, it's in fact going downwards in terms of number of new cases, and our death rate has flattened out. And importantly, in terms of resource utilization, in California, they estimate, this is the website reference for this is here on the bottom, the estimated the number of ICU beds available is about 2,000, and we were never overwhelmed, and we flattened out now around 800 beds being used. So there's plenty of resource availability, which is going to dictate when tier 1 surgeries can occur. And that's shown again in this slide, which I'm going to zip through. And then in the Bay Area, you can see that, that the resource utilization of ICU and non-ICU beds is going way down for COVID patients. So in that setting, CMS recommendations regarding which types of surgeries to do included tiers 1 through 4, which we're all familiar with, and you know, availability and especially availability of ICU beds was very important. Supply of PPE to the system and urgency of the procedure were all things to consider. And about 2 weeks ago, tier 1 surgeries were opened up at Stanford University, not including cosmetic surgery at that point. And so basically any surgeries that were non-cosmetic were allowed to occur. And I'll talk about the testing protocol for these. And this included functional rhinoplasty, by the way. You know, what we want to do as surgeons is make sure that patient safety and staff safety intersect when we take a patient to the operating room and when we see patients in our clinic. And I think this study, which is the one that Rick mentioned, is something that's worth talking about because it gets quoted a lot. And this was a retrospective multi-center review at the height of the epidemic in a center in Wuhan. And they identified 35 patients who had COVID symptoms or COVID without pre-op symptoms. The problem is the denominator was never identified. So you don't know how many of these people or how many people they actually had in the entire study. So you don't know what percentage of people without testing were showing up in an endemic area with this. Because what we want to do is avoid taking patients to the OR who are positive. And no patients were being tested pre-op at that point. So this is a figure from the study. And as Rick mentioned, 15% of these, 44% of these people entered the unit, and 21% ended up dying. All the deaths were in major surgical procedures like major abdominal surgery or hip replacements and things like that. And all of these patients had comorbidities. So what are we doing at Stanford? We want to avoid that type of situation. Of course, that risk does not work for us for this type of elective surgery. The first thing is patient preparation. And again, as Bowen said very nicely, the goal is no COVID positive patients should enter the clinic or the surgical suite in any way because of the risks that engenders. We will treat patients like they are positive and be careful, but still we don't want to even have them in there and take steps to minimize the above. So for us at Stanford, our protocol, and we have okayed cosmetic surgery, and it's been okayed by the Santa Clara, our county health department as well, is as follows. In patients in whom you're going to do a non-powered instrumentation surgery in the nose, we do PCR COVID testing 72 hours ahead of time. In our testing at Stanford, there's a known 4% false negative rate. These patients are quarantined, they're already quarantining, and as the quarantine is lifted, in the county, we have to come up with a number like 7 to 14 days for these patients to be quarantined that we require for them. And if they fail to do that, we can do a rapid test, which is thought to have a similar, not quite as good false negative rate. If you're doing powered instrumentation rhinoplasty, non-intranasal, so in other words, piezo on the bones or things like that, we will double test these patients 72 hours ahead of time, they quarantine, and we do a rapid test, so double testing. So the likelihood of a false negative getting through becomes extremely low. I'm no statistician, but it becomes extremely low. For rhinology and skull-based surgery, I'm just going to mention, I don't do that type of surgery. For that, you know, intranasal aerosolization risk is higher, but it's the same testing protocol for them. If the patient isn't positive and they're not doing some emergent skull-based surgery, they do not wear PAPR, by the way. Patient preparation, I'm going to mention betadine. I think that Dr. Rourke is going to talk about this at length. There's some evidence for virucidal activity, and studies are underway. The references for this are down below. And transacemic acid, I think he's going to talk about as well, and there's a study on that as well. So those are things that I'm not doing yet, but I may consider doing, and you may want to consider doing if there's no downside. From a surgeon point of view, everybody who enters our facility, who works at our facility, or who is coming as a patient, and by the way, only patients are allowed in, not other visitors, are screened with the screening questions that are pretty standard, and temperatures are taken. In addition to that, for all of us, we're tested with a PCR and so on. During surgery, we wear eye protection, surgical mask, and there's a HEPA filter on our suction, so that addresses that issue. Nasal surgery, the same type of thing, except we wear an N95. This is true for all mucosal surgery, intraoral, even eye surgery, eyelid surgery. And you have to make sure your OR has adequate air exchanges and you have a HEPA filter on your suction again. And rhinology, it's the same. As I mentioned, all staff are screened before entering. All of us have been PCR tested. I've been tested 4 times actually, and antibody tested. We can debate whether that was really useful or not. I know epidemiologists don't think so. And everybody's screened every time they enter the hospital. So our goal again is to keep our patients safe and to keep the community safe by not overwhelming the healthcare system capacity. And I think you're going to hear the message a lot that, you know, today we're going to talk about and have a discussion about things, but evidence is thin at best. Again, what we think is true today might not be true tomorrow. And we have to avoid creating absolute recommendations until we know the truth. The best interests of our patients, staff, and community are what we have to keep in mind. And you have to look to your local governments and hospitals for recommendations for your community. What happens at Stanford isn't necessarily what's going to be working for you elsewhere in California or elsewhere in the country or the world. And we want to avoid making wide encompassing statements and guidelines at this point. And that's it. Thank you very much for your attention.
Excellent. Thank you, Dr. Most. It's very, you know, there's so many issues, and I do want to, I want to have a couple of the panelists weigh in because, you know, again, at Stanford, it's a major league institution, and then most plastic surgeons are going to be in private practices and doing these in small outpatient surgery centers where things may be a little bit different. In fact, why don't we go right to Dr. Ghavami, if you could unmute your mic and tell us, Ash, how you're approaching it in your facility at this point.
Yeah, thanks, Jay. Thanks for letting me be a part of this. I think, you know, especially being in Los Angeles, as Sam was talking about, it seems to be relatively a hotbed, but actually the numbers he gave me were encouraging because I know that it was a hotbed in Northern California first. So seeing that Northern numbers have gone down, ours has gone up, means that we're next on the list to go down. So I think we are past the curve. And that's why the governor of California did not issue an extension for certain phases like elective surgery not going on, and didn't use the verbiage of cosmetic surgery not happening after May 15th, because the last published date in the state of California to at least start phase 1 was May 15th, and he didn't extend that. He just extended overall what's happening. Just today I was driving, the farmer's market, which has been closed for 2 months, was open. Grocery stores still have 6 feet outside lines. So the bottom line here is there's some liability here, you know. Aside from us wanting to do the right things for our patients, there's liability with our staff, there's liability with patients. I don't know about Europe, Italy, and Turkey, but there's a lot of lawyers and that are hungry and that have been out of work for the past 2 months, and they are hungry. So it won't be hard for a disgruntled staff member to get a hold of a lawyer that's just, even if they don't win, just the nuisance to your practice, just the fact that everyone in your practice knows you're being sued by an employee might give them ideas. If a patient hears about it, God forbid you're popular on social media, I always am concerned about that. Inherently, you're a target if you're known, because the way they bring you up is the way they bring you down. So let me go through what I'm kind of doing in my practice briefly, and I might share my screen to show you my waiting room and some of my forms, but we have a questionnaire, a lot of what Sam said we're doing, and it's basically a slightly toned down version of what Sam is saying, because Sam's working in a hospital-based, university-based institution. I'm in a private practice, outpatient surgery center clinic on 2 separate floors in a tall building in Beverly Hills. So let me share my screen and I'll show you. So we have a questionnaire. We have anybody who's walking in my office has a PCR test that has been, enough time has passed that if it was a false negative, that some symptoms would show. So we're not allowing anyone that's coming from outside of California that has to fly in unless they have a private jet. So I actually have, in 2 weeks, I'm operating on someone who's coming by private jet with just one person with them. So that's very different than flying commercial, going into the airport, being exposed. The way I see it, we're gonna have this risk, second wave or not, indefinitely for a long time. And we could do all the testing, everything we want. All it takes is one brother, cousin, or family member that lives in the house with our patient to go to the grocery store, not be cognizant of what they're doing with their hands, and transmit that. And then because we are the ones that have the money and we are the target, we get blamed. Now it's gonna be very difficult to trace it back to us for liability, but it's an issue we have to talk about, how we're gonna do it. And I think the main way that we can battle unscrupulous, opportunist liability issues is for all of us to be on the same page. If we have the same page, all the Rhinoplasty Society surgeons, and at least a large majority, are all practicing around the same time period during this phase, and we're all cognizant that we're doing everything we can in our practices, and we're doing some version of what Sam just talked about for our outpatient surgery centers, then that power of numbers is good, because we can use that data and that information as a way to say, look, I'm going with the norm of what my other colleagues are doing. I'm not an outlier. I'm not doing something extravagant or crazy. So let me just share screen, and I'll just kind of see if I can share multiple images. Well, I'll just show the video.
Just share it down at the bottom there.
Yeah. So here's can you guys see that?
Yes.
So you guys can see this is my waiting room. We have some of the chairs blocked off so you can't sit. So we went ahead and measured actually within the waiting room so that you can't sit next to someone else. Now, if somebody comes with somebody, we're discouraging that. If they have to, that person needs to be COVID tested as well. We treat them as if they're a patient, and they can sit next to each other, for example, right here. Now let me share my desktop. Let me just share my desktop, that'll be easier. So here's my desktop. You can see here this video. You guys see that video? So you can see in this video, we're showing the waiting room. And then I also have plexiglass in front, just like they do at the grocery store. Here's our station with temperature thermometer checking. We're checking everyone before they enter the space. They have to knock on the door. And here's the plexiglass in front of the receptionist desk. Could you all see that?
Yep, looks perfect.
Okay. So I won't bore you with my forms, but essentially nobody's coming into my space in the surgery center. And I think honestly, the outpatient surgery center, if it's well controlled, is one of the most controlled, possibly safest places to be for someone to walk into. And that's what I'm telling my staff, because no one's walking in there without COVID negativity status with PCR. I do think I ordered 200 IgG antibody tests, and I sent them back because the data is not strong enough, and I think it could confuse people. It'll give you a false sense of security that you're immune and you may not be. And God forbid you're positive IgM, but let's say it's a false positive and you're COVID negative, and then you have to miss work for 2 weeks. Guess who pays for that 2 weeks off? So there's a lot of issues that don't make sense with antibody testing right now. So I think PCR questionnaire, and then all patients, you know, ASAPs and ASPS and different society have sent out consent forms, and I'm using some version of those consent forms with some additions that they're basically saying, look, I'm taking a risk being a patient right now. I know that it's a risk, but as Rod Rourke says, thank God for plastic surgery. People still want plastic surgery, but if we do give into and kind of start going away from each other during this era, it's going to be a problem to restart. And the last thing I'll say is, you know, and this is really encouraging. I just did some math. So Sam Most was saying that 1,600 people in Los Angeles are hospitalized. 1,600, okay? Sounds a lot when you say it on Channel 4 News. Now, if the census is correct, which we know censuses are always low, there's illegal immigrants that don't count. A lot of people don't fill out that they're, I have never filled out a census, and I'm a family of 4. So there's 4 right there, not in the census.
You're in trouble now.
That's
Yeah,
right.
I
You
know.
just said it on tape, man. They're coming for
That's
you.
all right. I lost the form. I don't know. My dog took it somewhere. But
Yeah.
there's about 10 to 12 million people by census in LA. So I would venture to say there's closer to 15 to 20 million. So let's just be conservative and say the census is correct. If the census is correct, then there's 12 million people in Los Angeles. And I like the hospitalization data because hospitals have to record that. And that's accurate data. If you're hospitalized, you're getting recorded. Hospitalized COVID patients, 1,600, 12 million in Los Angeles. That means hospitalization rates right now in Los Angeles is 0.0001333. So
Not a whole lot.
I would venture to say that's got to be similar to the seasonal flu at this point. So we really need to be careful. That study that came out that I just have in front of me, that Rick Davis and Sam quoted, I think it is dangerous for us to go and publish things like this because lawyers think if something's on paper and it's published, it's something they can use. We have to be very careful what we publish. But so that's the gist what I would say to that. And then I think we're having a discussion at the end as well.
At the end, we'll round about. And I appreciate it, Dr. Ghavami. I'd also like to hear from Dr. Nazım Turkish about what Istanbul. Is there any major differences in your neighborhood in Turkey that you could note based on what we're doing here in the U.S.?
Well, well, we haven't started the surgeries yet because the government do not recommend the elective surgeries. So, but there are some surgeons illegally are performing here on the hospitals, and in Turkey we are, you know, we operate usually in the hospital base, different than the United States. We don't have the office operating room facilities. And I think for me, the most important thing is to prevent the patient. And I'm not thinking to start the surgery right now until the government recommends us to start first. Secondly, I'm not thinking that I will be able to perform a good rhinoplasty with the shield and the N95 mask and together with my magnifying loops. It seems to me it's like impossible because I started to see patients doing Botox fillers in the office, and even doing a Botox or filler with that mask is really tough for me. So if the quality of my results is gonna be bad, why to do that surgery? So I'm gonna wait so far. In overall Turkey, numbers are decreasing every day. Istanbul is the epicenter of the epidemic in Turkey. Is we have, today the number of new cases was 1,600, and the total of we have 4,000 deaths so far. Not too bad, and the hospitals were not really overwhelmed. I have friends in the state government hospitals working at the ICU units. They say that half of the beds are empty. So.
So you have to try out that.
Surgery, I'm going to take all the measures. Pardon me?
Did you mean 16 million or 16? You said 1,600 patients.
1,600 new case, detected case with the PCR testing. You know, in one day. 1,600 new cases in the 80 million population. Mm-hmm. And the total of the cases like 200,000 death, I calculate that 5 times more or 10 times more the people got infected. Still, we are around 2% of population got the virus. And so the risk actually pretty low. To operate a COVID patients, undertaking the necessary measures with PCR testing 48 hours before the surgery. And we, in the elective surgeries, like orthopedic surgeries, they do at hospitals, they do lung CT for every case, because in one patient without symptom, they detected COVID and the lung symptoms, and they found out that the patient is COVID positive, even though the patient don't have any symptoms. So I believe that chest X-ray is important, and with taking all the measures, you know, maybe I'm gonna start the surgeries a month later when the numbers goes down significantly. My risk will be less. Of course, I cannot agree with more from Ashkan because it's more important to prevent the patient and not to be blamed by the patients, and then not to get sued with operating a COVID patient.
Well, with that said, I think we should move into the legal issues. We have Dr. Rod Rohrich today to take us through some of the legal aspects and what he's doing in Dallas to really minimize the risk for patients and also to control the liability as best we can. So thanks, Rod, for joining us.
Thank you. So I'm going to share my screen and everybody see it?
Yes.
Okay. All right. You see my screen?
Yes, we do.
Okay.
Yeah, perfect.
So,
Yes,
you know, I think I'm going to go fairly rapidly through some of this because so many of you have already talked a lot about some of the points that I think are very important. And I'm going to talk a little bit about these, but the key is this is preliminary. These are safety things that are preliminary. And I think we can't overemphasize that. And these are my disclosures. And but, you know, it's a rapidly moving target. I mean, and everybody's been through this before, but, you know, for us, it's in Texas. You know, Texas actually has been very fortunate. We've been back since May. We've been operating since May 4th. I've done 10 rhinoplasties. And I'll just share you with my experience. And so we've been fortunate because in the USA, of course, it's been in the New York and Northeast area and the Northwest. And the number of cases we have, it's actually been a plateau. We're testing now 20 to 30,000 Texans a day. So our number of cases of positivity have gone up, but our hospitalizations have gone down and so have the deaths. So that's actually a good thing. And we never, just like Sam said, we never had a problem with insufficient PPE or hospital beds or ICUs, because that's one of the key things, that everything is local before you resume elective surgery. So everything I'm going to say is about local Texas and some USA. And we have these rigid practice form that we actually, before we started, I met with every one of our team from our day surgery center, our hotel, and our skincare center. We have uniform criteria that are mandated by all. And that's very important. And that includes the rigid screening and testing. As soon as you get off the elevator, you come and you get tested and you get your temperature. And that's just foregone. And then we don't have waiting rooms, so we don't tape anything off because we don't trust anybody. We don't have refreshments. We've cleaned out the magazines. I've canceled all my international patients for the next 3 months. And if they come from the USA in a hot spot, they have to quarantine in Dallas for 2 weeks. We're at about a fourth the pace we were last week, and this week we went to 50%. So, and then we disinfect all of the touch areas in every room, of course, after every patient. And so everybody's screened and scripted, and we identify the high-risk patients. And I think what Rick said is so important. We don't operate on high-risk patients now. And what Jay said is, he had me to add this thing about the legal considerations. I think, of course, you know, the pandemic that always occurs after any type of thing like this, we can guarantee it is going to be the legal pandemic, okay? It won't be the secondary surge that we can guarantee. So always take care of patient safety first. Protect yourself, the patient, and your staff. And do the right thing. You know, guidelines and standards of care, be very careful. We want to not talk about that. We need to talk about preliminary recommendations that are fact-based, not even evidence-based, but not bias-based. And I think that's really where we get into trouble. Because the science, as Sam talked about, is changing so rapidly. There's no dogma. Look at that. We talked about testing, no testing. Well, testing's mandated. Well, now it doesn't mean much. Masks, no masks. Now we do masks. I mean, this is so elusive. So we have to remain evidence-based, not emotion-based. And never say, I believe, because we're not preachers or ministers, but we have to say, this is what I know. And this is the one thing that I always tell my staff, I've never in my life said, I don't know so many times. And I think that's okay. But this was recently in the Washington Post, okay, because the second wave definitely is coming, and it may not be the pandemic from coronavirus, but it's going to be the lawsuit wave. So just wait for it. So it's going to hit us soon, just like it did with all the ALCL and the breast implants. So the key is no dogma, must be preliminary, and stay fact and evidence-based. And it's okay to say, I don't know. And I think that's very important. That's why we need to really not veer from making some guidelines or cogent recommendations and things that really probably are not even evidence-based in any manner. So we need to be very careful when we do that. I like both the consents from the ASPS and ASAPS. I like the ASAPS one a little better because it's a little more down to earth, but I have them sign it both for my staff and my patients. Now, that doesn't guarantee anything, but at least it tells you and tells them that you've informed them, you're following these rigid guidelines. That's the one thing that'll protect you, because somebody is going to get COVID, whether it's your staff or your patient. That's just inevitable. But at least you followed the same rigid guidelines. The daily staff screening, everybody, including us, gets that. If we have a temp above 99.6, you go home. And the same with the patients. They're rescheduled. So my manager talks to all of these patients and has a questionnaire before. They're not like, I recently had a patient that was coming from Boston, and I canceled her because she couldn't, you know, I said, until you're back in Dallas for 2 weeks. So virtual consults, I mean, obviously that's still something we do, but I do more follow-ups now. I only see my post-ops and new patients now, and they all come alone unless they are a minor. No one comes with them. We text them, we text them from the car. Everybody gets a surgical mask from my office, not the one they wear, the cloth mask, which is about 30% effective. So we get them a surgical mask. And we don't operate on these minimum and high-risk patients, as Rick mentioned. And I don't operate on sleep apnea patients either. All of these high-risk patients I'm pushing out for the next several months. And hopefully when things clear, and I think that data that Rick presented was interesting, but I think it had too many variances to actually be validated. I know it's going to be published, but the screening I think is important. The fever is important. So let's talk about what I do preoperatively. So I think the chest CT, PCR, and antibodies are the big things. I don't do chest CTs. And I think it's great. I think it's certainly in the symptomatic patient. The whole thing on multiple testing modalities is the biggest thing I can say here is we really don't know their sensitivity and reliability. You know, when the FDA lets anybody do tests without truly validating them, that's the problem. And I'm not saying that's bad, but it's been a pandemic. So we do the PCR test, because it measures the current infection, we hope. But how accurate is it? And this has been talked about several times. The deeper you go down in the nasal pharynx to the lung, the higher the rate of positivity. So it's not only the test, but how deep and how well you get it. If you go back to the nasal pharynx, you do a bronchial lavage, then that becomes very accurate. So that is also determined by how accurate your PCR is. I mean, there are universities now that are throwing out the Abbott machine because of the 15% false positive rate. So the bottom line on all of these PCR tests is, yes, it's the most accurate thing we have, but it's probably got a 15% variance one way or the other. So I guess if you repeat it within 72 hours, that does increase its accuracy a lot. But just remember, you know, in essence, you know, you're looking at a 70 to 85% accuracy rate, but you treat them all like we do it in AIDS. We treat them all like they're positive. And then that protects you and the patient. And if they have any symptoms, just delay them. So I think that's the most important thing. So for now, it's the PCR. That's what we do. And we don't do the antibody tests, and we don't do imaging. And obviously that's done in the hospital. And the antibody test I'm going to go over real rapidly, because we basically know that the problem with the antibody test is that their sensitivity and variance is so broad in spectrum that it's almost meaningless. And also, when the IgM elevates in the IgG, that's when you have a problem with the sensitivity of the test. So the quality and reliability, even by CDC, is basically unknown. So basically, I've had 2 antibody tests for my staff and myself, and you know, they've all been negative, but I don't think it means anything. None of them are truly FDA approved, and that's the problem. So with these antibody tests, I would say, let's not get a false sense of security. So what do? We do PCR, we do immediate pre-op screening, we do temperatures, and we measure the current state of infection. And the key thing is the screening with fever and all of the CDC expanded symptomatology. Then the day of surgery, what we do is they're met, and they come by themselves, and they're met with a series of questions and a temperature. Again, everybody has an N95 mask that's in the pre-op area. PPE, no visitors are in there. Waiting rooms are closed. So we actually use our waiting rooms for our lunch staff, for our staff. So, and then we do the preoperative decolonization. And I actually do this as well on myself for the last week for the nasal pharynx, and that's with betadine. Now, there's a lot of in vivo and in vitro data on it from the past, but it looks like betadine 10% is actually the one that's got the best antiviral. I've become a viral expert in the last month because I've reviewed about 80 articles on it. So betadine looks like it's a great antiviral, better than antibacterial, believe it or not. And there's a lot of studies that are coming up, like one from NYU, one from Stanford, and hopefully they'll be able to randomize it, but you know, some of them are still pending. But the data on the in vivo and vitro in the past with other coronaviruses has been pretty good. So that's what we use. And we don't use this is an American joke, but there is some data also on hypochlorous acid, which is also an antibacterial, and it's a very, very dilute form of bleach, but it does have some antiviral activity. And so this actually also is being studied now across the board. So, but data is really, really not out there yet on all the antivirals. Chlorhexidine, believe it or not, is not a good antiviral, which surprised me. It's Paradex. Tranexamic acid actually is a great antiviral, and there's some data that's now, there's 2 trials that are being launched for IV and for outpatient, inpatient, because it does prevent it breaks down the antiviral membrane, and also it actually may have an effect on the breakdown of the virus from plasminogen to plasmin, which of course is antifibrinolytic activity. So I actually have always, in the last 5 years, have used it IV, the gram of IV anyway. So it may have some potential positivity. So this is hopeful, but the clinical trials are pending. So betadine is the best. I like to use it 4-to-1 mouth gargle. That actually doesn't stain your teeth. It's still above what the published studies are. You can mix it with your favorite mouth gargle. I actually use Colgate, but it doesn't really matter. You can gargle with it. You can actually, you can use it for your irrigation. All my patients, like I said, all my patients, including the non-rhinoplasties, have used it, have had 0 complaints. They actually like it. They swish it for about 15, 20 seconds before surgery. And then in the operating room, the key here is everybody's in full PPE, N95s, face shields. And the other thing that's been touched upon is we have a high OR air exchange, and you have to have at least 25 exchanges per hour. Ours to get a 99% viral clearance, and our OR is 40 exchanges per hour. So every one of your ORs, you should be able to calculate that. And that's important. And we leave the room for 8 minutes when that happens. And then and the door is not open except for, and we're texting. So we have actually whiteboards outside says when intubated, when you can come back in. So my circulator texts me when I can come back in. And then of course the face is prepped with a full betadine prep. The mouth is prepped 4-to-1. The nasal pact is 4-to-1 with Afrin moistened pledgets. And we use nasal swabs that are full strength. So basically, it's a betadine shower show, and we've put the throat pack in, and then I use an occlusive dressing. I'd use Tegaderm. That helps to further prevent any type of aerolization when you're doing that. And then, of course, we're coming in and we're fully dressed. And I empathize with Nazem, because I tell you, after about 2 hours with an N95, and I actually wear a mask on top of this, so it gets like you're pretty hypoxic or hyperemic or hypokypnic, and we're in full protective eye gear. And so that's kind of the quick overview of that. And in the last 2 minutes, I'm just going to talk about rhinoplasty or fillers. And basically, it's a similar thing. And we use in our office, we basically prep, and I've always prepped with chlorhexidine because it's the best antibacterial for any fillers. But what we now do the mouthwash gargle for the patients as well. And then we do for nasal fillers, I swab them with a betadine swab inside the nose. And that really is what we're doing here in this patient that I just did the other day. So basically we will swab them, and then I'll prep the inside of their nose with that. And we will do that bilaterally. And then we'll do the filler, and of course with shields on. And then the key also, when you're doing a filler, make sure that when you're doing it, that you're actually occluding the nostrils and trying not to be inside the any type of mucosa when you're doing that, so that when you finish, then you can actually, so minimally palpate that. And I think that's one of the things that they've got to be careful of. So with that, I will leave you with being safe. Operate only on COVID negative patients to the best of your knowledge. Protect yourself and your staff. Use chlorhexidine for skin prep, especially in the fillers, and then in the nostrils, and anyway with nasal mucosa. Use betadine. And of course, just remember, we need to validate all of these. It's constantly evolving, and let's try and stay science and fact-based, and always be willing to say, I don't know, because honestly, we don't know. And obviously, as Sam and others have said, put the patient's safety first. So thank you.
Thank you, Rod. That was excellent. And I think we should have some discussion before we have Dr. Hogg talk about the findings from the RSE webinar that was a couple weeks back. So just to open the discussion.
Can I ask a question of Sam?
Shoot, Rick.
Sure, you might not get an answer, but sure.
Well, I'm impressed that the sensitivity of your PCR is 96%. How do we go about that? What are we doing wrong?
So this is a test developed in-house at Stanford by one of the
so they're just probing a different part of the RNA, or?
No, that's not. I mean, Jeff was talking about 99% at Duke, so
Yep.
It's not that much.
But is it really been validated to be that, Sam? Because I mean, everybody says they are that, but is it really?
I wasn't part of that. Well, actually, I was part of that process accidentally. But I trust them that they've been able to validate it. They've done tens of thousands of people apparently, and that's what they found. So.
Well, I know that the technique of probing the airway is,
Well, no, I mean,
I was tested and I asked the person doing it, and they said, I've never done this and no one showed me how to do it. So I took a Q-tip along. I said, look, you don't go up to the olfactory bulb and rupture through the cribriform. You go this way. And she goes,
I can speak to being tested because I was tested 4 times. But the first time I was tested was actually a flu test. So they just did a middle turbinate swab. That ended up being positive. I mean, we already talked about this. So that worked. And then a nasopharyngeal swab was the second time. I can tell you the last time I had it done, and I've been tested negative twice, was I did feel like they were going to sample my my pituitary, because they put that thing in there all the way back, held it for 10 seconds, and then twirled it for 5 seconds with a full 1001, 1002 count, and then took it out.
That's
And so
Well, they were doing both
that was
sides at
negative.
the clinic here. So
Yeah, so if that was negative, it was going to be negative. And I think one of the people posted a question or a point, which is that the PCR test tests RNA, not live viral particles. So, you know, I was confident when that was negative, that I was truly negative, that it would have found any little dead particle of virus that was in there that could potentially give you a false positive.
but they're not all probing the same gene sequence. There's more than
Yeah,
one,
correct.
you know,
Yeah,
codon that they're probing. So
I
the
can't
other
speak
thing-
to the
the other thing that's
exact
important is that
biology of the Stanford test, but it's considered a high quality test. And for us, you know, we don't take tests. I think Jeff talked about this, or someone else did. We don't take tests from, only take tests from particular places. The only places outside of Stanford will accept the test basically around here at UCSF and I think Davis. So we won't take a test result and consider it a valid test unless it's from one of those places.
Can I weigh in here,
how
Jay?
you
Yeah,
capture.
go ahead, Dr. Berkowitz.
A lot of try to change the signal to noise ratio here a little bit. There's the practicality. Sam's at Stanford. I'm in Santa Clara County in the shadow of Stanford. I don't have Berkowitz and Zeidler don't have the same access to testing that Sam Most has at Stanford. And I think that's true for most of our listeners here. So what is really out there that's available, that is highly reliable? And that is LabCorp's nasopharyngeal swab PCR test that Jeff Marcus mentioned. And we do that 2 weeks before the surgery at the time of the pre-op. And then that screens them out. If they're positive, we change the schedule. We push them out. And if they're negative, they're quarantined for 2 weeks. Then we run a second test 3 to 4 days ahead. And that will be the Pixel test from LabCorp that the patient can order, delivered by FedEx. It's the anterior nares. It's not all the way back. Very high specificity. It's gotten good reviews. It gets FedEx back to LabCorp, and you'll have an answer in 24 to 48 hours. The saliva test, which we thought was going to be our godsend, we spent hundreds of dollars, thousands of dollars on saliva tests for our patients, and we found that they were so backed up in the lab, they were 4 weeks out on giving us results. So as wonderful as that test is, it is probably, that company is not really up to speed yet. The ideal thing is a point of care test. And that's what Sam has. He has a Cepheid test. I can't get Cepheid test at Berkowitz and Zeidler. We're trying to get McKesson, Henry Schein, and Fisher, and Cardinal Health all have access to the new Sophia test, SOFIA, from Quindel out of San Diego. And that test is supposed to be very accurate point of care test that we could do on the day of surgery or the day before surgery. These are things that will be practically available to our listeners.
Sure. I'd like to hear also from, sorry, go ahead.
Can I say a few things?
Yeah, absolutely. Dr. Guyron.
Yeah. First of all, as being the oldest person on this panel, I'm going to really appeal to the sense of realism. You're listening to so many variations of the preoperative care. First of all, we need to make sure that when we take the temperature, which is, in my view, one of the most important, reliable guards, we need to make sure that the patient is not any medications that may reduce or take away fever, like it's being on steroids or taking Tylenol or any other medications. Second, when we talk about I don't do such a thing, we need to be careful. Those are the ones that actually they're going to come back and haunt us. Those are the ones that the lawyers are going to review these webinars and just, oh, so-and-so said that I don't do this. We have to have a really good reason for not doing it. I heard several people tell us that I understand the packing. Packing actually can cause serious infections, problems on somebody who doesn't have any virus disease. But what is the reason for not using, for example, doily stents? What do we have? What do we have against it? Or even turbinectomy? Yeah, wait, we have to be careful. We do conservatively anyway. So I think that we need to be careful about these things that we say that I don't do it. Those are the ones that is going to give the lawyers a reason to come after us if something goes wrong. And I think it is important for us to just set the stage properly and yes, do some tests. And for example, about the out of town patients, what Rod is doing, yes, it is a very remarkable thing. How practical that is, or what Ash is doing. Not every patient has a jet. So what I do is have them tested before they come to see me. When they come to see me, when they get in town, we do another test. I tell them use mask in the airplane and sanitize their hands. And I think those are the things that, and if I don't do out of town, out of country patients for the period that we don't know when that's going to be, my practice is going to be down to 20%, 30%. That's not sustainable. So we really need to use common sense and realistic facts, and also things that they really have been proven. Others, common sense is going to guide us what to do.
Yeah. Jay, can I say something real quick?
Absolutely. Go ahead, Ash, and then Dr. Rorik next.
So yeah, so I guess I misspoke. I didn't say it in absolute terms. I'm only doing people with private jets. So let me clarify. So until June 1st, we don't have anyone in the schedule that's out of town except for one person that happens to have a private jet. And that's why I made an exception. And the only reason I'm waiting till June is just because I want this first 2 weeks to kind of go by for us to get our bearings and see how the flow is going to be, because this is all new to us. I've never had to check temperature of a patient, have them knock on the door and come in. I've never had to wait for an outside lab test to come in. What if they're backed up and my whole schedule gets screwed up? So there's a lot of logistical problems with this. In theory, everything we're saying sounds great. But me personally, I do have a plan, and I have patients booked all through the summer, and a lot of them are out of town, just like yourself, Dr. Guyron. So what I did is they have to get tested after they land, and they have to demonstrate that over 7 days they have no symptoms. They do a symptom log, and if necessary, I test them again. And there is a test in LA that has a 48-hour turnaround, but I'm not gonna cut it close, so they might get 2 tests. But I'm waiting till they fly. If they're exposed, the next day after they land, they get a COVID test, and they have to quarantine themselves for a week. Now, I might change this, but 7 days before surgery, they cannot come into the office. So, and then all new patients are being done virtually. So I have no follow-ups. If anyone says my nostril, this and that, tough luck. If you want to go to Yelp, go for it. I'm not seeing you right now. That's not an emergency. We're seeing basically new consults with virtual. Extra people are not allowed to accompany our patients. They wait in the car. We text them when they can come pick them up from the hallway. So in our space that we're protecting, we're not a hospital that can have positive pressure, or I'm sorry, negative pressure space. So nobody's coming into my office who doesn't have a COVID negative status. That's it. If they're flying in that town, we have to just wait for the certain time period. And you know, the other practicality is I wore an N95 mask when I was pre-oping 5 people on Friday, and they were all spaced apart. I could barely breathe. I had to take that mask off when I went into the back room and just breathe. I don't know how, for those of us, especially that do cases that require a little more energy, like liposuction or a tummy tuck, I don't see how I'm going to wear an N95 the whole time without, you know, passing out of CO2 poisoning. So we have to talk about practicality too, and how long do we need to wear an N95? Is it just during the, you know, the initial phase of the surgery? Do we switch it out, or are we just having it if we have to assist in intubation extubation? The only person in the room that's going to have intubation extubation is going to be my nurse with an N95 assisting if they need cricoid pressure or something, and the anesthesiologist. And we're waiting 10 minutes to enter. But I mean, these are all theories. They're all theories.
Well,
Ash,
they
but
shouldn't be
we need to
theories,
make
though.
sure that the patient is tested before the patient comes in town, because if they come in town and they're positive, you're going to send the patient back. You're going to have the patient to contaminate the airplane and all kind of things. I think they need to be tested before they come in town.
Okay.
Well, you know,
I agree with that.
actually, I addressed
Rod.
with my ID person who was on the Ebola task force bombing, and I agree. We need to use common sense because, you know, when I say I cancel, I'm just pushing them out. You know, if he has told me, if you're from a true hotspot in the United States, you need to, if you're going to have it done, you need to come to Texas, Dallas 2 weeks before, get tested, and then get tested again 3 to 4 days before. If you're not from a hotspot, you come, you wear a regular mask, and then you get tested when you hit the ground like 3 to 5 days before in Dallas. So that's really what it is, because I'm like you. I mean, half of my patients are from around the US and a lot from around the world, but I'm not doing any outside. Well, I have a patient that's coming from Guam, but he's on an air base, so he's secure. But you know, we have to use just practical stuff that makes sense. And the best thing we have to do is be uniform so that all of the criteria, when we get asked, is that we've done that for everybody. And I agree with you about the temperature. I mean, that's really probably the most important frontline thing, because I don't think we should rely so much. I think testing can get you into trouble because we're lulled into complacency. Because I don't care how many people on this call say that their tests are so accurate. I can tell you the data would not support that your test is 95% accurate. The data would say it's 70 to 85% accurate. And that's why some hospitals are not using the Abbott anymore. And so we have to be very careful. And to answer Larry's question, every one of those tests is local. You know, Quest may be great, CPR may be another. So, I mean, I just tell people what works for me in Dallas. And I can tell you, you know, we finally have the saliva test that works for us in 36 to 48 hours, but it's so local. And Sam is great because he's in Stanford, but I think we just have to be very practical. And Ash, take them out of the waiting room, get rid of the tape. Don't let them come in. They just will violate it. I can tell you.
That's right.
I don't trust myself, my staff, or my partners. So guess what? We all voted to just, we actually have the chairs barricading the reception area. I know it looks terrible, but let's just not let them come in there.
They can wait in the car. Yeah.
Wait in the car. And you know what? You know what the most amazing thing in this whole crisis has been? You know who's been the best? The patients. It's unbelievable. I mean, and these are patients that, you know, used to wear us out, you know, like, you know, say, oh, Dr. Rick, it's this little swelling here. They've been unbelievable. I must say, I'm shocked by that. So pleasantly so. You know, it's actually been our patients. Our staff's been good. You know, my personal staff has been excellent. Some of my OR staff, honestly, I'm doing a lot of the testing for them because I am really, really, you know, there's a lot of angst. Now, it's calmed down a lot in the last 2 weeks because they have to understand and feel that you're being safe. That's the most important thing, that we're being safe for them and for us. That's why they all love the betadine gargle. I'm actually doing the betadine wash myself, and anything I can do to decrease my viral load, that's okay too.
Well, let's, in terms of what to do and how to do it, with the Rhinoplasty Society of Europe webinar a couple of weeks back, I'd like Martin to go through the salient findings, and then we'll open up for a big discussion and take some questions from our webinar participants. So, Martin, can you share your screen and go ahead?
Yeah. Thank you, Jay. It's a great pleasure and honor for me to be here and part of this. And I would like to share with you my presentation. All right, everybody sees it?
Yep, it's perfect.
Okay, great. So my name is Martin Hoog. I'm working as a plastic surgeon at the University Hospital in Basel, and I am the chair of the scientific committee of the RSE. And in terms of this, we conducted this webinar 2 weeks ago. Unfortunately, the video is not running very well, but no problem. We invited several international experts and opinion leaders on rhinosurgery. We brought together several questions in different categories, and the aim of the webinar was to get consensus on important questions: how to get back to the OR, in the safest way possible. So I'd like to share with you the results. As I said before, we had 4 sessions with different questions. The first session was about outpatient consultation. These were the questions, the voting that we performed during the webinar, and the results and recommendations that we the panel draw out of these votings. So the red ones are the consensus, which means more than 75% of the panelists agreed to this question. The blue ones are no consensus, but majority, it's lower than 75%, but it's still the majority. So consensus could be reached on the necessity to screen the patients by using phone or a questionnaire in terms of COVID symptoms. And if the patients reveal symptoms, then the recommendation and consensus is to perform a RT-PCR test before the patients are coming to your private practice. So in the practice, social distancing, of course, is important. That has been mentioned before. Concerning a COVID area, the panelists recommend to have a kind of COVID area, or at least a room where you may separate high-risk patients in private practice. If you are handling with low-risk patients, FFP1 masks are good for the patient and the healthcare workers. That's the majority of the panelists agree to this. And in case of high-risk patients, and in case that high-risk maneuvers are necessary during the outpatient control, FFP2 and 3 masks or N95 masks plus shield are recommended. Increased airflow turnover strongly is recommended by the panelists. Also, there is no consensus on this. Standard disinfection of high-touch surfaces, this is a consensus, should be carried out after each patient contact. So coming to the second session, pre-op patient assessment. Again, these were the questions, the voting on these questions by the panelists, and the results and recommendations. So the adaptation of the medical history taking in terms of asking for fever, dry cough, sore throat is of utmost importance. This gives a very good orientation about the status of the patient. Also, the panelists recommend to carry out pre-op RT-PCR tests 2 days prior to the operation, not 2 times and not 5 or 7 days prior to the operation, but only 1 time and 2 days prior to the operation. Preoperative self-quarantine is recommended by the panelists, although this is no consensus. Antibody tests are not useful at the moment because false negative results are too high and cross-reaction may be present. Also, there is, to the knowledge of the panelists, there is only 1 validated test for this virus. Another question was, should we carry out aesthetic rhinoplasty? The panelists agreed, the majority agreed to really very conservatively draw the indication for aesthetic rhinoplasty, and if it's possible, just postpone to a later date. On the other side, functional rhinoplasties are appropriate to carry out at the moment. This is a consensus, given the fact that in the operation room, personal protective equipment is used in an adequate way. So session 3, different intraoperative measures in terms of improving safety. Again, the questions, the votings, powered instruments, piezo, laminar airflow. The recommendation of the panelists were, again, a consensus on carrying out antiseptic packing prior to surgery and intranasal pharynx disinfection. Betadine, this has also been mentioned before by Rod, has proven its value in the treatment of other SARS viruses, Ebola virus, norovirus, and it works very good. It lowers, or there is no virus load detectable after use of betadine. So coming to the situation in the OR, if aerosol generating maneuvers are carried out, the panelists agreed to recommend to use FFP2 or 3 masks or N95, and part instruments are known to generate aerosol during the operation. Still, the panelists were not willing to prohibit the use of powered instruments and piezo, but at least the panelists strongly recommend that these instruments should be used in a very differentiated way, and maybe only simple bone maneuvers without extensive mucosal defects should be carried out, and use cold instruments whenever you have the feeling that this works the same way. Laminar airflow, again, is strongly recommended also. There is no consensus on this. Session 4 about legal aspects and problems. Again, the questions, the votings, and the recommendations of the panelists. Consensus has been reached concerning the fact that complication rate may be higher while operating on patients with undetected COVID-19 infection or patients which are getting cross-infected during the operation. Consensus could also be reached concerning the importance to adapt the informed consents in terms of cross-infection of patients and the risk of this. Another thing is the responsibility of the surgeon. Is he responsible for the complication, for the higher complication rate? The panelists agree that the surgeon is not responsible because if a patient is cross-infected during performing of rhinosurgery, this could be considered as a complication and not as a malpractice. Again, a question was discussed whether to resume to elective surgery at the moment is appropriate, and the recommendation of the panelists are to really conservatively draw the indication for aesthetic rhinoplasty, postpone if it's possible, and resume to functional rhinoplasty at the moment is appropriate. So that's about it, and thank you for your attention. I can't hear you.
Sorry, that's an excellent summary from that webinar, because those questions were posed to people that some had already started doing surgery, some were thinking about it. Here in Los Angeles, we're starting up this week. So I think from the aspect of hearing from the experts in Europe, that's a very valuable webinar with those questions being answered. I'm glad you could share them with the Rhinoplasty Society here in the US. I do want to open up for discussion, and I know
Jay, one question.
Yeah.
Would you allow me to do the first comment on my presentation?
Absolutely, go right ahead. And then Dr. Robati, I know, has already asked me to get in here too.
I think we should handle these recommendations in a very differentiated way, because mainly these recommendations are based on expert opinion, and as we all know, the evidence is very poor on several aspects, also on several questions that has been posed and discussed in this webinar. Also, the panelists agreed that there is a necessity or need to repeat this webinar maybe in 6 months with a better evidence base at that time. And one thing which is very important, panelists do not see these recommendations as a kind of rule book or definitive best practice guidelines. I think it's very important. Everybody who is taking under consideration to use these recommendations has to adapt these recommendations to the local situation, the local rules, and the local recommendations of the hospital and the official authorities. I think this is very important to tell everybody.
Agree 100%. This is and that's why my opening comments were please to understand that we're not a regulating body. We're not a governing body. We are rhinoplasty surgeons with an extreme concern for safety of our patients, our staff and ourselves. So with that, Dr. Robati, you had some
Well,
comments
Jay,
you wanted to make.
Thank you for inviting me as well. I have a main worry which is dangling in my mind, and it's partly been already stated by Barman. But after saying that, we have all picked very useful things these days: PCR, antibody tests, distancing, PPPs, self-quarantine. I am implying everything, in all these in my office. And I've not started operating. We should start at the end of May. But having said this, I have one concern. Actually, I have two big concerns. Number one, how can I bear physically a way of operating which is so unused to me? I've made some patients' dressings, not dressings because I've not operated anybody yet, but I've looked into some people's noses with this stuff, and I'm wondering how I can do a rib which will last me 5 hours. And having said this, I have one intellectual doubt. If we are reasonably confident, which is the main thing, to take someone in the OR who is negative, meaning who is, to the best of our knowledge, non-COVID patients, then should we renounce on the quality? I mean, why should we not put Doyle splints in a nose? Barman has already said this. Why should I not use power tool if I love power tools and I have a good relationship with them? And why should I not use piezo on a bone which has not been in contact with any mucosa? So if I renounce on all these things because somebody tells me to do so, otherwise it can become medical, legal, even dangerous, I don't even think I should begin. So I have a big intellectual honesty issue here. I'm not going to renounce on my quality. And to get quality, I need to do certain things. And if these certain things are criticized for many reasons, maybe I shouldn't do them.
Well, criticism is different than data. And yep. I have to tell you that, you know, I get very uncomfortable with things that are stated in absolute terms, absolute terms that are exclusionary or exclusive to certain techniques or certain ways of doing things when we don't have any data. So I think if it's uncomfortable for me to use Doyle splints, then that's for me to decide for me. But if I'm comfortable with Doyle splints, I believe I have a COVID negative patient and nobody can tell me otherwise that using Doyles or not using Doyles, there's no data to show it, then I'm going to use my own best judgment. And so everybody has to decide for themselves in these times until there's data telling them otherwise. You don't want to, quality is number one. You have to do a great job for your patient. Absolutely. And whatever it takes for you to do that, you have to gain a level of comfort that you're doing the right thing for them and keeping yourself and your staff safe.
And I think one thing,
Rod, go ahead.
Just to remember, just because it's published does not necessarily mean it's true. As
sure.
Editor of our major journal in plastic surgery, okay, just because something's published does not mean it's true. And I can see that from that recent article, because it makes absolute no sense about not using Doyle splints or anything like that. Now, mucosa from turbinate, maybe there's some, but there's no data on that, but at least it has some type of common sense from, as a rhinoplasty expert, as all of us are. But the Doyle splints thing, and I also agree, if you get the result you want, you shouldn't do it.
Let me just chime in, just because I had mentioned the Doyle splints at the beginning, and it isn't, it's not that using them, that the placement of the splint is a problem. The problem is when they come back 5 to 7 days later and you're going to remove them, and the first thing they do as soon as you remove the splints is they either sneeze or they blow their nose, and that's the issue. It's not it's not the placement of them or the fact that they're there.
But we're in the same N95s as we are in the OR, Jeff. Having done
exactly
10 of them now, or I mean, we're in the same thing. I wear the same things I wear in the OR. That's the difference. And I actually even have an RX air emulsifier. No, it's not as good as the OR, but we do the same thing. And I think,
well, here's the bottom line. Let me just say this real quick. What Enrico said is correct. If we're assuming we're doing all this stuff that everyone coming into our space, when I say space, I mean OR, clinic, whatever it is COVID negative, and our staff's COVID negative, and I would suggest we test ourselves and our staff once a month, at least in this initial phase. Then technically,
I would disagree with that, but go ahead, Ash. Keep going.
I mean, I'm just recommending that we consider that because we don't know the data, and I'll get back to the data thing real quick because that's important too. The frequency of visits will matter. Now, whether they're coughing, sneezing, we can't control that. I mean, I have allergies and I cough and sneeze all the time in the morning, and I'm probably going to scare my staff's deathless. And I've already warned them, you guys, I cough and sneeze in the morning. I have allergies. I have issues. I have a huge septal deviation. I have to go see someone. But the point is that if someone's COVID negative coming in, then you have to trust that 5-7 days later, when you're removing the splint, you're already letting him into your office. Now, if you have a Doyle or not, they're already in your space. So it's from a liability standpoint, if that person turns up to be COVID negative, whether you use the Doyle or not is not going to change that for your staff's comfort, for yourself, et cetera. And as Rod said, in the clinic, we can be a little more relaxed because we're not wearing it for 2-3 hours straight. Wear all your gear when you're examining these patients, when you're removing their splints and their Doyles. Do it very carefully. Use suction. I have that whole little ENT thing in the side that has suction and it has everything on. So, so anyway, I think we have to assume everyone's COVID negative. So go ahead and do that. And the recommendations are going to change. And, there was one time where they actually said smoking might help this. And we all know how Rod feels about smokers. I was worried he was going to go get a pack of Marlboro Reds and start. So I made sure I was going to call him. But the data is going to change from time to time. It's not something that's rigid. And the problem with data collection is, and I would suggest, since we're all doing something slightly different, the data is going to be skewed if we do something prospective. It would be nice if a group of us could have the same things that we're doing so that we can do some kind of prospective study where we have 3 to 5 people in this panel who are doing the same things for the next 6 months and use that data to help our local organizations and the entire medical community by being in such an industry that's considered high risk as rhinoplasty and being the expert. So I would suggest we consider doing something similar in protocol and do some prospective study with numerous surgeons. That's going to be useful. And then we can look at that in 6 months and say, Rod, Ash, Jay, and Sam Most, did this exact same thing for 6 months. And then looking back, no COVID patients, or there was one COVID patient, nothing happened. Like, that's going to be useful data.
Sam,
Just a quick
go ahead,
point.
shoot.
I was going to latch onto the discussion about the Doyle splints and the turbinate reduction. It's all about risk mitigation. So, doing turbinates for me, I've continued to do them, but intraoperatively, I guess the risk is the cautery. I do a very small amount of cautery on the anterior head of the turbinate. I don't use any marker beater. I take a little bit of bone out and out fracture it. And the second risk is in the post-op period, taking out the Doyle splits, which I still use, which it's pretty rare for them to sneeze and cough and stuff. No. But really the biggest risk is the suction you use on your SMR cart. That's what that's called, Ash. The SMR cart. So that's the little thingy the otolaryngologists use. So that suction, generates aerosol. So we have to get inline filters for the single-use inline filters for that. And the third thing is we have actually installed this big, ugly HEPA filter, which created one of my exam rooms to be a negative pressure room. Because if you generate aerosols or think you did in a room, you can't use it for 3 hours unless it has high circulation. So most clinic exam rooms aren't set up like that. I showed a picture of that before. It's a really big thing. They're going to retrofit our building so that all the rooms have that, have the HEPA filtration. But so, I mean, those are just things. Everyone's going to be different. Every practice is going to be different, and the way you do things is going to be different. So it's all about your locality and what you have available to you and doing what you think is going to be best for risk mitigation for.
Hey, can I say one more thing?
Yeah, we're going to go around. I want to get last comments. So go ahead, Dr. Guyer.
Okay. Ash gave you some statistics, and I agree with that. I think this is the fear of this virus has paralyzed all of us for the last 2 or 3 months. And it is a reality. It is there. It is something that we need to be careful about. But changing the way we do the things drastically is not necessary. And we really need, again, to be realistic about what is that we're doing? What are the possibilities that under the conditions that we all repeated several times, that we're going to have actually somebody who's going to have the virus, which is one in so much. One out of 100, 2 out of 100 of them are going to be in a hospital, and 1 out of or 2 out of those 100, small percentage are going to have to be in the intensive care unit. This is something that is really, we need to understand, be realistic about it, but also we need to be careful about what we do and implement some of the measures that they are sensible, not to get out of control and worry about it so much that we change everything that we do.
Thank you. I want to have Dr. Davis, final comments.
I think this is still, in my mind, a tough thing to grapple with. You know, when we start talking about potential mortality for a purely cosmetic elective procedure, that sobers me up quickly. This is a highly communicable disease, and unfortunately, it appears from the early literature, and I'm not talking about that paper out of Wuhan, but this consortium of collaborators. This viral infection at the time of any surgery could conceivably accelerate the disease. That patient may have gotten it in the community and been able to sleep through it at home. After 10 days, they're feeling fine, but because of the stress of surgery, maybe nutritional depletion, maybe hormonal changes, maybe immunologic changes, and the fact that they have to heal the wounds, that's the reservoir of the infection. That could conceivably be a game changer if it happens at the time of surgery. That's my biggest fear. That's what's keeping me up at night. Granted, the probability that we'll operate on somebody with the disease, probably pretty small, and depending on where you live, probably very small, but there's still a chance that some, 16-year-old kid could not be around because they picked the wrong time to have their nose surgery. And I'd have a hard time living with that personally. So I'm giving very serious consideration of just retiring from medicine. Very serious.
Well,
what it's worth.
You know what, Jay? I think after that negative statement from somebody, Rick, that I really like and trust a lot, who's considering retiring from the surgery because of this, I may be considering retiring sometime in the future, but it's not going to be because of this virus.
Well, I have some other concerns. I was hit by a different kind of virus 6 months ago. My office was hit with a cyber attack, and that hurt me more than this COVID did.
Yeah, but I understand. I really am
all
sorry
of that
about
collectively. I'm just thinking, the cost of getting HIPAA filters in my office and all, and the fact that I may still not be able to create a safety net that's good enough to protect my patients.
Yeah,
I'm not saying that I'm criticizing anybody else. I have to act on my own conscience and what I feel is appropriate. And I'm struggling with this. I'll be honest with you. I'm not convinced
what's true
yet.
for you. I mean, for Rick Davis, that's what is true.
Can I just finish it? I understand that, but you obviously have, unfortunately, because of the negative experience, so you're loaded with the all the negative things that can possibly happen. But this should not get us down. This should get us more realistic about the things that we do and what we do, how we do it. And when the statistics tell us that actually, under the circumstances, the way we behave ourselves, protect our patients, we can actually have a single patient in the operating room who's going to get, a 16-year-old going to die, then we obviously will stop doing what we were doing. But
right.
A fear of that should not really make us stop what we are doing.
I agree. Go ahead, Rod.
Okay.
Final comments from Rod Roark,
I agree.
please.
We have to stay and be positive. We must focus. You cannot change the past. You cannot change the future. You can only change the present. And in the present, we must stay, science-based, fact-based, because there's a lot of non-science out there. And, And I respect and love Rick as well. And I think in that cohort, though, what puzzled me was when they said that same cohort, the mortality ordinarily would be 8.3%. Now, if we have an 8.3% death in a rhinoplasty, we should not be doing any surgery on any patient in aesthetic surgery or rhinoplasty. So I would say we will get through this. We will be stronger than ever. We just have to have the precautions and do the right thing for our patients, put patient safety first. We're going to get through this and be stronger and actually be better than ever before, because we'll use common sense. I have not changed my rhinoplasty technique. Now, I don't do a lot of turbinectomies. I haven't changed my rhinoplasty technique because if I have to change to get the same result, if I can't get the same results, I'm not going to operate on somebody. It's like saying that's why I don't operate on smokers, because I don't like them and they get worse results. So I would say stay safe, stay focused, stay positive. We'll get through this. We'll be better together.
Well, that's part of my problem. I do mostly 6-hour cases and, tertiary, quaternary, pentanary rhinoplasties, rib grafts, fascial grafts, and it becomes a kind of a major surgery in that patient cohort, as opposed to a primary just need some tip work. So I'm looking at a little bit higher mountain to climb at a time when operating with all this crap on your face and not being able to use the instruments you'd like to because of putting your staff at risk or your patients at risk. Just, I don't know what to tell you. I hope all of you are successful. I hope every one of you has no problems whatsoever. I sincerely and honestly mean that. I would not wish well on or harm on anybody. But I just have to follow my own gut here, and so far I'm very undecided. I wish I had more time to think about it, but you can't go without eating very long before you start to get hungry. So there is an economic component to this that we're kind of dancing around, but our practices are being decimated, and people depend on us for their livelihoods, and our kids need college tuition, and we, et cetera, et cetera. I'm looking at losing my health insurance right now. And
unfortunately, I have to get up because I have another commitment right now and past that. I apologize. I thank you for getting me involved, and let's just think about the positive things in the future. Thank you for having me.
Appreciate it, Bauman. Thank you so much.
With us, Bauman.
Dr. Cherkish.
Well, me, you told me?
Yes, please.
Okay. I will tell you my opinions, and if I start to operate, I'm not gonna use that N95 mask and the shields, because I believe that they will not protect me 100% if the patient is COVID positive, and it is my own risk, and so the quality of the result is very important. If I will do a surgery, I'm taking a risk, even though it's very low, and I will do all the measures and the tests not to operate a COVID positive patient and to minimize the risk of the possibility of to operate of the patient. This is important. I believe office patients coming to my office who are not tested are even more risky than the patient I will operate, because we do not test the patients when they come to office, just take an history. It's not possible so far. So, and I don't think all the measures mentioned can protect us 100% if we operate a COVID positive patients. So that's why I wouldn't change my operative technique. Actually, I don't use that power instruments, but I don't see a reason not to use them. Also, turbinate surgery should be done. If we use suction, if the patient is really is carrying the virus, is COVID positive, anyway, all these measures will not make too much sense. These are my my comments.
Thank you, Nazim. Dr. Berkowitz.
Yeah, I just wanted to tell everyone on this panel, you're all amazing people, and I look up to you for all the good advice you've given. And Rick, we've all been where you are. We were forced into a 2-month vacation, the most exhausting vacation all of us have ever had. None of us got any sleep, but we're now on the front lines. That's the reality. You're moving to the front lines. And this is what I told our staff when we started doing surgery last week. We are now going to the front line, and we have to conduct ourselves that way. And each case will be a little bit different. I have 2 practical things to offer for this group. I don't know if you can get my slides up, Jay.
We don't have time, unfortunately. You can send it around to Jeannie. She'll distribute it.
I'll tell you very quickly. There are 2 practical things. Number 1, we're intubating patients under a polyethylene clear plastic shroud. So what's being put in by the anesthesiologist with a video laryngoscope, the shroud's left on for 10 minutes, then taken off. That minimizes aerosolization into the room. It's a very, very practical way of doing intubation. Secondly, I purchased a Duramax dental aspirator. So we should be looking to our dental friends for advice. They're hurting worse than we are, especially the dental hygienists. And the way they're going back to work is with high volume vacuum, 3-level HEPA filter vacuums. Duramax is the name of the one I ordered from Bayes, B-E-Y-E-S Dental out of Toronto. This machine's about $2,700. You put it underneath the patient's head, and they've shown smoke analysis. It just sucks everything right down under the patient, just like a Genair on your stove. And it's a practical thing to use. It's the only way the dentists are going to be able to get back to work. They're back ordered now, but we can get them. There's a company in Wisconsin that makes them as well. It's a little bit noisier, but it's not. But it is readily available. I'm getting the one from Canada. So that's my 2 pieces of practical information if you're going to go back to the front lines.
Perfect. Thank you, Dr. Berkowitz. Dr. Marcus? You're unmute.
Thanks, Jay. It's getting a little late in the hour. I wanted to say thank you to you and all the panelists. I think it's been very helpful.
Great. Thank you.
Jay, can I say something real quick? So a statistic that this one actually social media person told me that I looked up and it was true. The average age of death from COVID is the same as the average age of death.
That's an important statistic.
Interesting statistic.
Dr.
I just want to.
Dr. Sajadian?
I can't.
Go ahead, Sam. Sam, and then Dr. Sajadian.
And that we can't, we can't mix this up with the flu. And I think, I don't know, I'm probably the only person here who had it. And I can tell you I was severely, severely ill. And I'm not afraid of the flu. Okay, so the morbidity isn't, he said 2% of people get hospitalized. That's not true. It's like 20 to 25% people can end up hospitalized. And it's very, very serious, even if the mortality rate is really low. And the reason why the mortality rate is low is because these people are being hospitalized and helped. So, I mean, this isn't like the flu. I do take it very seriously. I don't think that we need to go as extreme as what Rick's talking about. I feel very sorry that he's feeling that way. On the other hand, I don't think we can avoid change in our practices. And I do think, just like other things like using universal precautions after HIV and Hep C and things, we're going to be doing things differently. And like Rod said, we're going to be safer and better for it. That's all I want to say.
Okay. Ali.
Yes, I just wanted to share a couple of points that I made in my last slide quickly for the benefit of the attendees. First of all, thank you, Jay, and everybody for this fantastic webinar. I really think that we're learning new things about this virus every day. We should just stay nimble and flexible and adapt as we see. And everything is really local. But because we don't know the tests, we can argue that the tests are not 100%, definitely not 100%. They could be up to 80, 90%. So testing and retesting is the key for the pre-op of the patient. And as you mentioned, making sure the patient is in this with us and staying quarantined pre-op and post-op in order to minimize our risk. Even if they're tested and negative, you can't really approach your surgery and say, oh, okay, it's guaranteed that they're negative. So you just have to keep those in mind. Thank you.
Martin.
Yeah, Jay, thank you very much again for having me with you. This was really a great webinar, and I learned a lot. And I don't want to come over too pessimistic, but these days I had a long discussion with one of our infectiologists, and he told me that we have to live with COVID. We cannot beat it, but we have to live with it. On the other side, this is the opportunity, and as Rod said before, we will be stronger after this, developing things, concepts together, and we have to concentrate our power on getting more evidence-based. Maybe one of the best sayings this evening was not fear-based, but evidence-based. And I already wrote the paper on the consensus that we made 2 weeks ago, and we have to develop this together and stick together. Thank you very much.
Excellent. Dr. Robati, last but not
Just
least.
echo the same feelings. I was very sad actually to hear Rick's opinion, because I don't think this is probably enough reason to get to such kind of choices, but we just need data, and in the meanwhile we just have to face it. And the only way we face it is taking all the precautions possible, not bringing in the OR people who are positive. And then once again, I do not think I should reduce my quality doing things under local anesthesia or doing teleconsultations post-op exclusively, which in my opinion is not feasible, and other things like this. I'm not prepared to that.
Well,
I think local anesthesia is the worst. Why would someone go under local anesthesia?
Well, that's a recommendation again from somebody.
That's ridiculous. I'm going to say that right out loud. That is ridiculous. The best thing to be is intubated.
Absolutely.
Because you have a closed system. When you're under local anesthesia, and I've done cases, you know, in my office in the OR, they're coughing, they're sneezing, they're coughing a lot.
Absolutely.
You're stimulating
100%.
the airway the entire time. It's the highest risk thing you can do.
All right. Well, I want to close up with everybody. I really appreciate the panelists for coming on, doing a great job. This is a very key topic for our practices, and this will probably show up on the TRS, on the Rhinoplasty Society website. I'll make it available for the panelists as well, if you want to put it up as well for people to see. And I really think this was important, and we will do this again soon after operating for 3 or 4 months. And I think we should kind of come up and see what's working and what's not. I don't think we're even close to done with discovering how good we can be for our patients.
You bet.
So thank you very much, and have a good one.
You bet.
Thank you.
Take care, gentlemen. Be safe.
Be safe.
Bye-bye.
Thanks, everybody.
Thank you. Thanks.